Thank you, Don, and thank you to the organisers for inviting me. I always love coming up to Bangkok to talk to the regional audience that this has really become. And it's also, I think, really appropriate that I'm talking this morning, after this morning's session, because I really wanted to organise that. Actually, my co-principal investigator on this study was David Cooper, and it was a real privilege and a lot of fun for me to work with him over his last 18 months or so on that study, and I certainly miss him dearly. These are my disclosures, and then in the next 20 or 30 minutes, this is what I'm going to talk about. I want to give you some context of why New South Wales decided to deliver PrEP in the fashion that it did, and that was to do it quickly, in targeted fashion, and aiming for very high coverage, then to present you the results of what happened there, and to talk about future challenges that we have, and then more broadly about lessons learned that I think are applicable in many settings around the world and not just in ours. So to give you some idea of New South Wales, it's a pretty big part of the world. It's slightly larger than Thailand, but it has a much smaller population of about 8 million, of whom the great majority are concentrated in the Sydney region. So there's about 5 or 6 million who live in that small area. But there are challenges in healthcare delivery in such a system with getting to the towns and villages that are all up and around the 1,000 or so kilometres up and down our coastline. So before we introduced PrEP, we had a period of quite stability in diagnosis. So this graph represents between 2009 and 2015 the proportional diagnosis in different population groups. So the blue is men who have sex with men. And you can see that a constant, roughly 80% of new diagnoses were in men who have sex with men. Most of the remainder are in heterosexuals, and very few in injecting drug users in our setting. During that period, we had a real focus on the treatment as prevention approach. So there were enormous ramp-ups in HIV testing, and these are HIV testing rates at publicly funded sexual health clinics in the parts of Sydney where most gay and bisexual men reside. And so you see over that period the rates of testing basically doubled. We saw a real revolution in when we started treatment. So this is a graph of the proportion of people newly diagnosed with HIV who are on treatment within 6 months of that diagnosis by CD4 count at diagnosis. So you'll see in 2013, only about a third of people with CD4 counts less than 500 were receiving antiretrovirals within 6 months. And our guidelines changed to universal treatment just shortly before that. But by 2015, 4 out of 5 were receiving treatment within 6 months of diagnosis. So a really fundamental change in the way we approached treatment of early HIV infection. In 2016, we reckoned that we reached in our state of New South Wales the 1990 goals, which the UNAIDS had set us. But despite all of that progress with treatment as prevention, in this graph, which presents the quarterly numbers of infections per year, you see we had very little progress in numbers of infections. So the totals, roughly speaking, were around about 350, with the exception of this peak here of a bit over 400. So this was rather disappointing and led us to conclude that in our setting at least, treatment as prevention was not enough on its own to achieve our goals. And I really emphasise, I'm not saying treatment as prevention is not important, it's critical. It's a critical part of the equation. But what I am saying is that in our setting, and I think probably in most settings in MSM, treatment as prevention is not enough to see rapid reductions in HIV. The other critical thing that happened was that in 2015 at the CROI conference in February-March, the UK and the French studies released their results showing PrEP efficacy of close to 90%. So suddenly we went from a rather confused finding of the from the EPIC study of possibly 40 or 50% efficacy to an understanding that it could be around about 90%, and that in fact in those studies the only PrEP failures were in men who were not taking drug as prescribed. And we did have a small-scale demonstration project of about 400 people, which was in the field at that time, and it was showing really good rates of adherence. People were continuing to take drug and 0 infections on PrEP. So putting all of those things together our State Health Minister, Gillian Skinner, announced funding for the EPIC New South Wales study. So this is, while it was a study, it was really an implementation project. It was statewide and it was large scale. And I really want to highlight that an important part of this, why it was introduced, was that we had a state strategy which had a very ambitious goal to virtually eliminate HIV transmission. So the Health Minister and her advisors could see, based on the 2012-2015 data, that unless something fundamentally changed, these targets could not be met. And that was incredibly helpful to have that target out there and accepted. So why did New South Wales decide to do it in the particular way that we did it, this rapid, targeted and high-level rollout, rather than just make it available, have doctors prescribing it to who they wanted in a clinically reasonable fashion? This was largely, our approach was largely guided by mathematical modelling, which suggested that if you wanted to have maximum population health impact, you should roll it out quickly. You should target it for maximum efficiency and minimum cost to high-risk gay men, and you should do it with high coverage. And if you did all of those things, and the red line is our projected incidence rates in Australia without PrEP, and this blue line is if you did all of these things, introduced it quickly, targeted, and with high coverage, showing enormously rapid reductions. Now, you might be sceptical about that, but it's not rocket science. The randomised controlled trials show 86% efficacy. If you apply 86% efficacy and you get 90% of high-risk people taking it, and you factor in herd protection, you get these enormous declines. If you don't have high levels of coverage, you get much lower levels of reduction in population incidence. I think it's really important that we think in doing this to reduce HIV at the population level, that we think as public health scientists, that we think even in the same way that vaccine scientists think. Many countries are familiar with vaccine targets and reaching those targets and keeping them to prevent the reoccurrence of infectious diseases. I think we need to think in a similar way with PrEP. So onto the study, the EPIC New South Wales study. We targeted this based on local epidemiological knowledge. So it's basically old-fashioned know your epidemic stuff. This will be different in different settings, and different settings will have different quality of data available, but in an MSM epidemic, it's not going to be very different to this. These targets and these incidence rates are local incidence rates based on a cohort study in Sydney. Essentially, I'll just abbreviate these as rectal STIs or syphilis, condomless anal intercourse with a partner not known to be HIV negative, and use of crystal methamphetamine in our study, as well as the data you saw in our setting, as well as the data you just saw from Adiba. Use of crystal methamphetamine is associated strongly with risk behaviour. We had 31 clinics by the end of the study, spread across New South Wales, but most of them were in the Sydney region, about 1,100 kilometres from one end of the state to the other. And we thought we needed to recruit in the first year about 3,700 men. We did that based on compromising between our wish to get every single high-risk man on PrEP within 12 months and a pragmatic consideration of how quickly our clinic network could do that, our public health clinic network and our private clinics seeing gay men. So that number was got from the size of the male resident population, estimates from a national sex survey or from a couple of national sex surveys that about 2.3% of men identified as gay, and a bit less than 10% of those who met one of the 4 criteria I showed in my previous slide. And we additionally, to get to the real high risk, initially had a requirement of ongoing risk of having at least 10 sexual partners at least 6 months and these other things. We did that mostly because we didn't think we could cope with recruiting 10 or 20,000, which it would have been had we not had those criteria. Other than that, the inclusion criteria were completely standard for PrEP studies, that they be adults in our setting, that they have a 4th-generation negative test. We did want to try to exclude prevalent infection, and that they not have acute HIV infection or impaired renal function. Our primary outcomes that we listed that we wanted to look at were set as being 12 months after the recruitment of the 3,700, that we would look at a within outcome of HIV incidence per 100 person years. Based on the risk behaviours we saw, we expected this would be between 2 and 4 per 100 person years if PrEP was not effective. And a population, that's a statewide level effectiveness outcome, which was a before and after comparison between those two 12-month period based on surveillance data. And from that surveillance data, we were able to extract data on recent HIV infection. And the reason we've concentrated on this is because in many settings, and including in ours, a substantial proportion of new diagnoses of HIV are in people who have had HIV for many years. So clearly you can't prevent an infection that happened 2 years ago with something you're introducing today. So our focus was really on these recent infections as defined by having an HIV negative test in the last 12 months, having an indeterminate Western blot at diagnosis, or being diagnosed with a seroconversion illness. We ascertained our outcome, HIV infection, through calling HIV a protocol-defined serious adverse event. So clinics had to tell us when one of these occurred. Clinics, with a couple of minor exceptions, all had to have electronic data extraction tools so that we could simply suck out, if you like, the electronic test results without them having to fill in case record forms. We didn't want to burden the clinics. And we could detect, through matching between the clinics, diagnosis at any one of the clinics. We also sought consent from participants to link with the state HIV register. We knew that wouldn't be popular with everybody, so we did not make it a requirement to participate, but 80% of people gave us their consent to do that. So we think we probably only missed HIV infections from people who left the state, but also those who stopped testing. So this is our enrolment curve to the end of the study, and the end of recruitment was on April 30 last year. But the analysis I'm presenting today are of that initial protocol specified target of 3,700. We reached that target much earlier than we thought we would, in 8 months. And at that time, because it was very clear from clinics that they believed that a lot of high-risk men continued to present, we amended the protocol formally to enrol as many high-risk men who have sex with men who presented. I'll rush through these slides because I don't have much time, but just to let you know that our baseline characteristics were roughly representative of new HIV diagnoses in the state. We probably had slight under-recruitment of the very young, and we had slight underestimations, as it's shown here, of overseas born. And you'll see in a minute what we tried to do about that when we discovered we were under-recruiting particularly gay men born in Asia. About 40% of men were from the inner city suburbs of Sydney, where the prevalence of men reporting being gay is about 10%. So the inner city gay areas, we call them. So in terms of follow-up, we had a follow-up HIV test in all but about 2% of our participants, and we had an HIV test within the 12-month window in about 3/4 of participants. We measured adherence through the medication possession ratio. The median was huge, reflecting the fact that more than 50% of participants took medication daily, but the mean was somewhat lower, and that was because we had about 3% of people not come back. That's people who came back once or not at all. We then had about 13% of people who came back about 2 or 3 times only, and about 14% who came back less than every time. Our within cohort incidents, we saw 2 new infections, both of whom were clearly not taking PrEP at the time of infection, for an incident rate of around about 1 per 2,000 person years. Remembering that we were expecting, in the absence of PrEP, 2 to 4 per 100 person years. So this is, we thought, an extremely good outcome in terms of HIV prevention, but clearly we still have some work to do. So the primary the population level outcome, just a reminder you, comparing this before period, the 12-month before PrEP rollout, to the after period, the 12 months after the first 3,700 were recruited, but noting that by the end of that period there are actually 7,600 men on, mostly men on PrEP. So the key result then, in terms of recent infections, we saw a 32% decline in that period. Just remind you that for the 5 years previously, we had essentially constant HIV rates. So within this short period, we were able to get a 32% decline, a slightly lower decline in all HIV diagnoses as we expected. The decline was somewhat uneven by population group, so we saw nearly a 50% decline in gay men older than about 35, and in the youngest group of gay men, essentially no decline in diagnosis. By region of birth, we saw nearly a 50% decline in Australian-born gay and bisexual men, and a smaller decline in Asian-born gay and bisexual men and other regions of birth. In terms of area of residence, in those inner city areas where gay men are very well community attached, where there was a lot of publicity about PrEP, we saw a 50% decline. And in the outer suburbs of Sydney, we saw essentially no decline. Sydney is an enormous, geographically enormous city of about 5 million people, and it does seem like we've got real work to do in those outer, very ethnically diverse suburbs. So we saw very gratifying incidence reductions within 12 months, but we did see some inequities emerging, and these are big challenges for us in the future, the young, the dispersed around Sydney, and the non-English speaking. So in terms of what lessons we've learned and some future issues, there was a lot of innovation involved in doing this, and clinics at times were overwhelmed. We had a couple of clinics where there were 2,000 new participants at a single clinic, and this was difficult, there is no doubt about it. We did make use of nurse dispensing at some of these clinics. It was a study which required consent, and we did group consent sessions. We had up to 20 people attending an education session, and so that the doctors who took consent could say, "You've received education, do you have any questions?" rather than doing the education themselves. But some clinics did need new doctors. We had large-scale promotion of PrEP, which I'll show you in a minute, in multiple languages. The whole process required vastly improved partnership with other players in the field, and we sometimes call this HIV prevention version 2. So we had weekly meetings where we had researchers, governments, sexual health clinicians, community-based organisations, all in the same rooms, identifying problems early and responding to problems we were seeing. I can't underestimate the role of ACON, as New South Wales Peak Gay and Lesbian Community Health Centre, or health organisation I should say. They did an enormous amount of work in building health literacy to have gay men understand that there was a new and effective form of HIV prevention, because at least initially there was a lot of scepticism from gay men about why they would want to take a pill a day, would it be toxic, would it work, those sort of things. So just some of the forms of education that were done. These were both as posters at clinics and on the street. Very simple messages because PrEP is a simple intervention. When we discovered that we weren't recruiting enough Asian gay men, we started specifically to target Asian gay men and gay men from other non-English speaking backgrounds. You see around Sydney these sort of PrEP promotion posters. They were used in the top 6 community languages within Sydney, of which a non-English community, of which one was Thai. And critically, it was promoted not absolutely on its own, but as part of combination prevention. So I think this rather innovative campaign from ACON, it portrays different gay men doing different forms of HIV prevention. So these guys here saying that they use condoms all the time because they're simple and they prevent HIV. This one here, these two here saying they're HIV positive and they stay on their treatment to keep themselves undetectable. And these two here saying that they take PrEP. When PrEP received national subsidy, we had a big challenge as well of transitioning men off the study and onto publicly funded PrEP in Australia, and ACON again had a very key role in that with promotion about how men could get PrEP through our pharmaceutical benefits scheme. So for the future, we know that we have more challenges. We're not where we want to be yet. We do have more work to do. And one of the key things is achieving and maintaining high enough coverage. And again, vaccination thinking, I think, is critical here if we want herd protection, which is part of the efficiency, part of the effect of PrEP. And so we're setting up systems where we can monitor coverage of PrEP and predicting what predicts a gay man who is high risk but is not on PrEP, because they're the missing link in this in trying to get it down to towards elimination. And some of those groups I've already mentioned to you. To finish with, I know this gets complicated, and some of the times you're probably thinking, well, wow, that's Sydney, I wish that's New South Wales, I wish we could do that, but we never could. I think I was struck when Andrew Hill was talking this morning about that moment in 1998 when the world said HIV treatment is too expensive and too complicated. Africa will never be able to use it. Middle-income countries will never be able to use it. We need to get past that moment in PrEP because in much of the world, TDF FTC is really quite cheap, and in fact in many settings is so cheap that now that we have these known population level efficacies, it's cost saving. It's not only cost effective, it will be cost saving in many settings. So I don't think we should be looking at these data, and you're about to hear some data from the US and UK which show similarly nice declines, and say we can't do that in our setting, because I think we need to make it happen. And parting thoughts, I think when we talk to our policymakers and when we think about PrEP, we need to aim high. This isn't about just the individuals, it's about populations. We actually have two interventions here, treatment as prevention and PrEP, both of which at the individual level are probably, in adherent individuals, are greater than 95% effective. And in that setting, it's about getting the treatment to the right people and having the people understand why they should be taking it to keep their adherence high. If we want to get good value for money, we want to target well. So we want to know who in our setting is at highest risk of HIV and act upon it. I've mentioned the coverage factor. It's, PrEP, there's no doubt about it. It's great for individuals. It keeps them negative. It reduces anxiety related to sex. But it's, if you maximise coverage to high-risk people, it's also great for populations. And then, politicians, at least in my settings, they work in political cycles, whether it's a 3 or a 4-year election cycle or how often it is. They want something that they can see before the next election. And that is worth encouraging and saying, if we do it properly, we can start seeing results in 12 to 24 months. This is not something that's beyond the next election. It is worthwhile doing to get me elected. And I couldn't finish this about thanking the huge army of people involved in PrEP implementation in New South Wales, and the huge army of participants as well, and those investigators across Department of Health, community organisations, the clinicians, and at the Kirby Institute in Sydney. Thank you.